Welcome to the Neurostimulation Podcast. I'm Dr. Michael Passmore, Clinical Associate Professor in the Department of Psychiatry at the University of British Columbia in Vancouver, Canada. The Neurostimulation Podcast is about exploring the fascinating world of neuroscience in general and clinical neurostimulation in particular. Every week, we're going to explore how neurostimulation works, what are the latest research breakthroughs, and how that research is being translated into real-world treatments that can improve health and well-being. So whether you're a healthcare professional, a researcher, a student, or just somebody who's curious about how our brains work and what we can do to help them work better, this podcast is for you. My mission is to make the science accessible, inspiring, and relevant to your life. This podcast is separate from my clinical and academic roles and is part of my personal effort to bring neuroscience education to the general public. Accordingly, I would like to emphasize that the information shared here is for educational purposes only and not intended as medical advice or a substitute for professional medical guidance. Always consult with your healthcare provider to discuss your specific health needs and treatment options. Today's episode is presented by ZipStim Neurostimulation. ZipStim is the neurostimulation clinic that I operate. You can find out more about our clinical neurostimulation programs at zipstim.com. That's ZIPSTIM.com. Today's episode dives into one of the most exciting frontiers in neurostimulation, remote supervised transcranial direct current stimulation, or RS-tDCS. And in particular, we're going to have a discussion today about RS-tDCS's potential to transform care for people living with multiple sclerosis. I'm joined by two leading voices in this space, Dr. Charvet and Dr. Pilloni, specializing in neurostimulation research. Together, they have led a series of Class 1 sham-controlled trials evaluating home-based TDCS paired with cognitive and motor training for multiple sclerosis symptoms like fatigue and hand dexterity. Their work not only demonstrates feasibility and safety, but it also lays the foundation for scalable, accessible, and personalized neurostimulation in the neurorehabilitation field, delivered right from home. In this conversation, we're going to unpack the design of their study, the results, challenges that they experienced, and the real-world implications of their research, and what it means for the future of remote neurostimulation. So stay tuned. I think you're really going to enjoy this conversation. Welcome back to the Neurostimulation Podcast. I'm really excited today to be joined by Dr. Leigh Charvet and Dr. Giuseppina Pilloni. Dr. Charvet and Pilloni are lead authors on a really interesting study entitled Remotely Supervised Transcranial Direct Current Stimulation, Results from two Class 1 sham-controlled, home-based randomized controlled trials in multiple sclerosis. Dr. Charvet and Dr. Pilloni, thanks so much for joining me today.
Thanks so much for having us.
Yeah, thank you so much. It's a pleasure.
Oh, great. Maybe we could start by you introducing yourselves, helping us to understand more about your work and your background, and then we can launch into a discussion about this really interesting study.
I'll go ahead and start. I'm older. So I'm a clinical neuropsychologist by background and have a long history of working with people living with MS and many other conditions. And as a neuropsychologist, my entire clinical research program and career has been driven by recommendations. What can we do and say to help people improve their quality of life now living with burden of neurologic disease or psychiatric disease? And there's so many lifestyle interventions and non-drug interventions in particular that are really interesting to me to see if we can, again, help people augment what their therapies are to try to improve things. And so I was an early adopter of telerehabilitation for cognitive remediation, doing cognitive remediation to study it, but at home. And I did a home-based telerehabilitation trial with brain training. And that was an aha moment in that we were overwhelmed really by people who wanted to participate. We rapidly enrolled, and this trial happened to be 60 hours of training over 12 weeks, and we had really high fidelity to treatment or completion rates. And so I was convinced then that was the way to go, was that people wanted these things that you have to do repeatedly to get the benefit need to be at home right away to study even. And that's what brought me to TDCS. After that trial, I was fortunate to connect with biomedical engineers, in particular, Dr. Marone Bixson at City College. And he was very interested in home-based TDCS. And so we partnered in that way and developed our whole research program that's 12 years old now, which we can't believe, and also has an offshoot of a clinical telehealth TDCS service we can tell you about. But along in that journey, I was really so fortunate to connect with biomedical engineers as partners. And I call it clinical biomedical engineering because of the insights, from engineering and from clinical care. It's just a wonderful partnership. And that's how I happened upon Dr. Pilloni. So I'll let her introduce herself.
Yeah. Leigh mentioned I'm a biomedical engineer by background, and I study and train in Italy. And during my master thesis, I met with a physical therapist from Brazil that she showed me amazing results about the application of TDCS in to recover motor function in kids with cerebral palsy, and I was so fascinating. And I come from a small island in the middle of the Mediterranean, and that is called Sardinia. And unfortunately, we have a very high rate of multiple sclerosis. And it was the time when I was deciding how should I pursue my faculty career or change in industry. And I got the opportunity to apply for a PhD scholarship in Sardinia and propose my own project where I say, let me try if I'm able to replicate such an amazing result in cerebral palsy, even in patients with multiple sclerosis that also support motor dysfunction, especially in walking and upper extremity. And during this journey, I was very fortunate, and I think the fate put me together with Dr. Charvet, and I was able to spend some time here during my PhD, where I did a parallel study in patients with MS using TDCS. This small study was actually done here in clinic, but I was very fascinating because I was the only one in the lab seeing patient in person. And I said, probably I should now translate this project that was in clinic where I was seeing everyday patient. And I also understand what is the challenge, especially in big city like New York, to come every day for an intervention. And I said, probably we should repropose what I'm doing in a home-based setting. And this is how I was matched with Dr. And I think we have very complementary skills.
Yeah, definitely. Thanks so much, both of you, for that introduction. It really basically covers one of the first questions that I had, which was what in particular inspired both of you and your team to pursue this therapeutic option for folks with MS in particular. But I guess the second question that I had that follows on from what you were just describing is that with neurological disorders in general, but I think in particular, given the burden of chronic symptoms in MS like fatigue and cognitive dysfunction and obviously the motor deficits, maybe could you explain for viewers and listeners why it was particularly important to explore a neuromodulation solution that can be delivered remotely?
Well, the remote part is for access, deployability, availability, and sufficient dosing, which is key. So it's a fascinating and rapidly evolving world in non-invasive brain stimulation. We're all the way on the clinical end, right? We're very eager for clinical application. But if you look at the clinical trials, we have thousands of clinical trials in PubMed and really still no definitive clinical trials outside of depression. And that's because low sample sizes, but also underdosing. We really believe that you need at least 20 consecutive sessions to evaluate potential for benefit. And the vast majority of trials are 10 sessions or less, with a lot of 5 session or less, or even single application clinical studies reporting. And also with variable dosing parameters, we believe very much it should be a paired treatment so that TDCS is functionally targeted to the region that's engaged in a training exercise, even if it's for something like depression. And so that paired treatment is really a critical part of the dosing parameters as well. And that's underaddressed or underreported. And so while we have this huge volume of work, it's very hard to compare across trials, and it's very hard to have these definitive trials to guide us to getting to something that we can deploy to patients right away.
So the pairing, yeah, it's very interesting because I think it's emerging, obviously, as you're describing that because the TDCS is more of a priming, I suppose you'd say in general terms, mechanism, that pairing it then with whatever the target. Yeah, go ahead.
Yeah, like a boost, upregulating neuroplasticity and reinforcing things. That's why we started with cognitive training. So while the brain training games do work, it's a lot of work. And so I was thinking, could we potentiate this, right? More out of less training and have it be more durable. And that's really the whole start of everything. And so TDCS added in our over and over, we see this boost added to cognitive, motor, upper or lower extremity motor, or speech and language training, any kind of training, it will reinforce and boost. And then certainly we have other targets too, in terms of depression primarily and our work in fatigue and that kind of thing.
So do you mind, maybe talking more specifically about this study in terms of broad thumbnail sketch, and then we can talk a bit more about the details.
I'll start with the broad sketch and then Dr. Pilloni can start with the details. But so our whole goal, and truly patient-led, right, to try to develop this in practical way, like how can we use this in home right away? And it was really a lot of work to develop this very optimized home-based system and in collaboration with our early participants who really told us, I can do this, I can't do this, that kind of thing. So our goal was to facilitate research to get these trials that we need, these class 1 randomized sham-controlled trials. And so we did that with the 2 trials that we reported in this paper. So we've had, so as a single center, nationally recruiting for one of them, we've had 2 large-scale randomized sham-controlled trials, one in fatigue and then the other in upper extremity motor functioning, looking at that paired activity. We have gone on, unrelated to MS, but we've also just last year had a proof of principle that we can also be the single site for delivery of treatment in multi-center clinical trials as well, which is very important. So last year, we were a single treating site for the NIH's Recover Neuro study, which was evaluating treatments for long COVID, the cognitive involvement or aspects of long COVID, of which TDCS was one treatment. And so we were able to enroll 328 people across 22 sites in the United States with 50 sessions of treatment all in 1 year. So all of these, we just really want to advertise that we believe going home right away. First, it's going to be how ultimately this equipment is used, but that right away is a way to accelerate the clinical research that we need to moving it to clinical guidance and approval. So that's a broad overview. So those are our 2 proof of principle trials in MS with motor, and then the paired cognitive fatigue treatment, and then just also learning that we can reach a lot of people in this way. So it's a very feasible approach.
Yeah, thanks for that. Before Dr. Pilloni, before you maybe talk a bit more about the specifics, I was just curious for clarifying. So the class 1 designation of the trials, what does that refer to specifically?
So that's based on the PRISMA guidance level of evidence. And so you need 2 class 1 trials to meet that level A requirement for being considered to be definitively effective. So that's parallel, for instance, to phase 3 in the pharma industry. So it needs to meet certain design requirements and certain size requirements. And that's why we refer to that pyramid and the level of evidence in that way.
Perfect. Yeah, thank you. That's not so, but I just thanks for clarifying that.
Yeah, it's defined differently across different disciplines, but in general, these are large, definitive, sufficiently designed, randomized, controlled trials that are sufficiently rigorous. And those are few and far between, unfortunately, in the world of TDCS.
Yeah, congratulations for bringing that together and certainly. So let's find out more specifics about it. Dr. Pilloni, do you mind telling us a bit more about the nuts and bolts of the study in terms of the inception and the design and the methodology?
Sure. So the first study was targeting patients with primary progressive MS, with primary and secondary progressive MS. So our patients that today have like advanced disability, and generally they report like limited upper limb limitation in terms of not only movement, but also like manual dexterity. And so what I want to also to highlight that is that TDCS is not meant to treat a disease per se, but like we are more focused on treating like symptoms related to the disease. And it depends on the symptoms and on the per activity that we decide what kind of brain target we are gonna decide the brain target and then also the electrode placement. So for this first study where we enroll progressive patients, because they were completing during the TDCS intervention some dexterity exercise. We decided to target the primary motor cortex, placing the anode, that is the active electrode, over the primary motor cortex, and the return electrode over the contralateral supraorbital area. So in this way, basically, our hypothesis was that the TDCS should give a boost of the activation that was generated by performing simultaneously this. Patient completed for this study 20 daily sessions. The TDCS component lasts 20 minutes, but the exercise were about 30 minutes. So they have a little bit of exercise without TDCS toward the end of the session. And it was a randomized sham control study. So we have both participant assigned to active and participant assigned to sham. And they were performing the hand dexterity exercise with both the left and the right hand. And it was very interesting because what we found was that patient that was assigned to the active group reported an improvement in hand dexterity. But even if it was not clinical, it was not meaningful from a clinical point of view, his improvement was like a signal of improvement. And this is very important for progressive patients because they tend to progress. So what the rehabilitation should aim is like really try to preserve function in the patient. And mainly this one do you want to talk about the fatigue?
Sure. Yeah, that'd be great. Yeah, I appreciate that.
I also have to say, because I'm a very practical clinician, so this was typically older people with higher burden of disability, and they were incredibly good sports. So I can't tell you the amount of equipment that we sent home with them in these huge hand cams. It was all very feasible. So a lot of times early reviewers would say, oh, people can't do this, or a little bit ageist, or older people can't adopt technology, and just learned all of that is not. We've had people who just have never even really used a computer or laptop, and we can get them through. So it was really accessible. So that was another thing that we learned in that study, is just a very doable approach. And so this paired treatment, so we're targeting here the dorsolateral prefrontal cortex, the left nodal, is the go-to treatment for cognitive functioning. And the idea is that the frontal regions are the hub of selective attention, executive networks, and that kind of thing. And particularly relevant for people with MS is that we'd like to enhance speeded processing, right? Because that's the first thing that becomes slow, and then it can transfer to new learning and problem solving, and just speed up things to experience a cognitive benefit. And that we see that over and over. So we did speed of processing training with Brain HQ, which are these online adaptive cognitive training games with the frontal TDCS. And that's become the standard treatment really for all things cognition across all disorders. This is what we used with the long COVID study as well. We did a pilot first when we were developing the methods. And while we were looking to add on, we saw just a proof of principle signal and computer-based measures already at 10 sessions in our pilot study. But our patients also were telling us they were less fatigued. So we then did a pilot, showed a really nice drop with active versus sham, TDCS, and fatigue with that same treatment. So this trial the primary outcome was fatigue. So patients weren't recruited on the basis of having cognitive impairment or to target it. And the secondary outcome was cognitive functioning. So really interested just to see as well. And so this was a 30-session treatment, so for 6 weeks. And they did that paired cognitive with DLPFC, TDCS. In this trial, we didn't see any fatigue separate between the two arms, but both groups got better. So the active dropped just as much in our pilot as before, but also the sham did. So that's really an open question of why. So it's interesting. I'll mention this in the podcast, is we had an unusual sham. It was a very robust. We're very excited that he's sure that we were very much shammed. And so over those 20 minutes in each session, there was 3 injections of current, ramp up, ramp down. So that may have actually mimicked some active, or at least a low dose. So that could have been one of the reasons why we saw a sham response. Another reason would be that the active component could have been the cognitive training. Also unusual for fatigue trials, we excluded on the basis of depression. So it could be that depression is mediating what we see a lot in these fatigue benefits. So really interesting. Everybody got better with fatigue. Cognitive, though, the groups did separate out. So there was a clear, significant cognitive benefit for active versus sham TDCS on things like MS-specific cognitive batteries at the study, even though we didn't recruit on the basis of, or enroll on the basis of cognitive impairment. And interestingly, the cognitive benefit was greater for people with more severe disabilities, so higher EDSS scores. And the benefit was actually preventing a little bit of decline, so not significant decline. But I just wanted to mention that as well, because we're starting to see in some of the really newer depressions, dementia studies looking at depression and, for instance, in MCI, early Alzheimer's, looking at that preservation of function and prevention of decline, or so really stabilization. And anecdotally, in our clinical service, our clinical program, a lot of people use us that way to stabilize themselves and prevent decline versus looking at full recovery back to baseline.
There's a lot there. It's complicated. I appreciate that final kind of summary too, because I'll start with a question about what you were mentioning just before that, and then maybe we'll just quickly touch on that last piece, because it's subtle, but it's really important. The thing that I was wondering about initially has to do with that difficulty in distinguishing between these overlap symptoms like the fatigue, the cognition, and the depression, because it must be challenging in a way to control for those in an RCT like this, because conceivably, and I think in clinical practice, it's pretty clear that there's significant overlap with how those are incorporated into any kind of particular underlying pathology, and so then would potentially be prone to becoming treatable under the same sort of rubric. So
that's a great point, and especially for people. They say if you've met somebody living with MS, you've met one person living with it, because it's such a variable disease, and so everybody has a different symptom burden, and it's multiple. And so we call them amplifiers, so that you can turn up or down the experience of what's resulting directly damage from the disease. But that can be, two people can experience things very differently. And the amplifying factors include things like depression and fatigue and all kinds of things like that. And so we may be modifying that. And so we do include now, we just are starting we're really excited because this is very end to clinic use, but a very large, rigorous, nationally recruiting trial looking specifically at depression and MS with the secondary outcome of symptom burden. So looking at functional measures, but also just that experience of symptom burden. So we think that's really important. So that's a great point. We also, though, do have people come to us in our clinical service and was like, which symptoms should I target? Because things bother me on different days, or I have multiple symptoms, and that we haven't really been able to figure out a path forward other than doing one thing at a time. But it's really important. What are we doing here in terms of like overall improvement of quality of life?
Yeah, I guess at the end of the day, I think it's obviously important in terms of the designing and conducting a study that's rigorous. But I guess at the end of the day, if there's a global improvement in some of the, so we maybe call them soft, I hate to use the term softer, but softer symptoms in terms of more symptoms that I suppose would be more potentially amenable to some sort of expectation effect, that we'll just take that as a benefit as far as what the end up clinical impact would be. And I guess it would be potentially, maybe we can touch on this. I'll try and come back to this other issue of the, go ahead. Yeah, please.
You raised such good points.
Yeah.
So one of the words that you used was soft, and I want to mention that there's soft aspects to what we're doing here that we do think are beneficial that we really don't capture with research measures. One of them is, and I saw it just with the cognitive training study too, it's a framework for people to schedule their days, right? And so that alone, having a scheduled activity that's an action versus a passive receipt of something, it's an activity and action that you've successfully completed for that day, which for all of us, that has amazing secondary benefits. And then it's also a micro intervention to have contact, even just briefly, with somebody. We're live with video visit with people at every session. So that's definitely at least a micro intervention in terms of people checking in with you, being able to report and look at things. And we do find that overall structure helps people overall. And also we're trying to measure this now, looking at getting from A to B to habit adoption. Can you continue, pick it up, and can this be like an onboarding period where you have this scaffolding network that can help you adopt these healthier behaviors or whatever it may be to improve things going forward. Anyway,
it's really interesting. And as you spoke, it made me think that there's probably something else about someone bringing the equipment home and just having that sense of agency and control over their own, as opposed to presenting themselves to a clinic that's intimidating and feeling as though there's that power differential in the hierarchy where there's more ownership and agency over being that active participant in the treatment. That probably goes a long way also.
I believe in that very much. Yes.
Yeah. I guess it's interesting in terms of, I'm not even sure how exactly to frame the question about, but maybe either of you could expand on that a bit in terms of what was the importance of the consideration around designing the study in a sense to either identify benefits in terms of symptom improvement versus the notion that you alluded to there in terms of more of a stabilizing to prevent decline, right? Because there's important but subtle differences there in terms of how trials would be conducted that are interesting and I think probably often overlooked or not adequately considered when thinking of the results.
I'll take that and then I will pass it to Dr. Pilloni for some, but we just went for direct, can we move the dial
Yeah.
and improve this specific aspect of symptoms in a pragmatic way? So
Sure.
we're taking people with a lot going on because we wanted it to be pragmatic to be used. That's my mission. But can we move the dial? And so we didn't really think about what happened after the dial had been moved. How long do you preserve it? We don't really have any data. And then, so we just, again, I probably didn't mention this, but in this journey in 2019, out of patient demand, people coming out of our trials wanting treatment, people from all over the country, we have a tDCS telehealth service that's through Innovative Care here at NYU. And that's people across the country with all different conditions coming to us for individualized tDCS, which has been really a partnership learning lab where we hear all these things, right? And so we did notice that people use us to prevent decline. That's a very hard study to design, but also to sell. But I think now we're moving towards that. And so that signal that we saw in the cognitive trial may endorse that as also a direction that we should go. But we really don't, just because, again, you need the volume of sessions and we need markers as well, I think very importantly to guide use. And that's where I want to pass it off to Dr. Pilloni about, we think that we might be able to get some kind of integrated markers that could really guide treatment that would really be a game changer for answering some of these questions.
And I think here we go back to what is like all these mixed results in all the study. Sometimes they are also power enough and also very well structured, but what probably we are missing is we are not assessing the right outcome, because this is I think one of the major issue when you design a study. Like, it's not only like the right dosing, but then also picking up what is the right outcome. And sometimes we just rely on mainly like self-report scale, where like patient just report, like even for fatigue, like the study, we didn't really find any like difference between sham and active, but we also question ourselves sometimes. Probably it's because fatigue is just mainly self-reported by patient, and probably and is influenced by several other factors. So in this context, now we are just starting a study where we are trying to see if there is any kind of biomarker, physiological biomarker that we can use to see who respond to the intervention, and if it really like marks then benefit in this like self-report scale. And so we decided to run this study in a patient with mild depression. And the biomarker that we decide to pick is like heart rate variability. We decide for heart rate variability because because first of all, in one of our previous study, some of the patients were, because everyone now is able to track their heart rate variability, was reporting, oh, I actually found that my heart variability improved and increased during the intervention, and happened that they were like active. So we don't know, but this is what they reported. And then we were very interested because there is some now literature supporting that like people with depression report has lower heart rate variability. Well, we decide to explore in a better in a randomized and better structured clinical trial if heart rate variability can be used as a biomarker of response to tDCS. And in order then to move on to the next step, that is really trying to do some closed loop stimulation. So trying to really move everything toward what is like personalized, non-invasive brain stimulation, that I think is a very hot topic. And these results will come in a few.
Yeah, no, that's exciting. Definitely looking forward to that. And I think what we'll do as well for viewers and listeners is we'll put links in the show notes to not only the research, but also the clinical programs that you're talking about. And
Great. Yeah,
hopefully
sure.
people are interested, they can check that out for sure. I guess in terms of the hypothesized mechanisms, maybe you could touch on a little bit about what your thoughts are around what the study potentially is telling us about the underlying mechanisms of TDCS in MS in terms of the symptoms that were examined: fatigue, motor performance, and cognition.
Do you want to start?
We can start. And I think it's worth to mention that we don't do we do clinical trial, but we do also some mechanistic study. We completed a study where we trying to investigate the real trying to understand better what is the mechanism underlying this technology using protocol where we deliver TDCS inside the MRI. So to see both functional MRI change and also change in brain perfusion. So this study was done in collaboration with our colleague here at NYU in the radiology department. And basically it was run both in healthy control and MS patient. And so they completed like a single scan where we collect first baseline functional imaging and then brain perfusion. And then we turn on TDCS. So the participant receive the TDCS inside the board. This is with technology that we develop with esoterics that are like MRI compatible. And then we also collect data about brain perfusion and brain activation after the end of the TDCS. So what we found was very interesting. We are still working on the functional MRI side, but like for the brain perfusion, we found that there was an increase in cerebral blood flow when we turn on the TDCS. So meaning that like really something is, and this change was significant both in healthy control and in patient with MS. The patient with MS has a much higher, it was much higher, the change that we saw. And like this means that really like we are activating the, we are like generating stronger activation of the neurons. I think. And because then this result also in a higher oxygen consumption. But this one, it was interesting because like you can measure perfusion both like in a target way, like dividing all the different brain area in a global way. So we didn't find any specific like brain area that was more like where this change was there was significantly higher. But globally, we saw this increase in cerebral blood flow and oxygen consumption. So these also make us thinking how TDCS work. That is not really, we don't have to think like transcranial magnetic stimulation where you are very like specific in your target. It's more broad activation that we are gonna generate using TDCS, and probably we are gonna activate it also other area of the brain and indirectly.
That's interesting. I guess that maybe speaks to then how there would be some overlap in terms of symptom improvement if there's more of a broad kind of effect.
Yeah. And then across disorders, so a lot of that's specific findings in some of our participants with MS, but there's a lot of just broader known mechanisms and increasing long-term potentiation and that kind of thing, and markers of neuroplasticity. So that boost is across disorders. There's a lot of both disease-specific, but also broad mechanisms at play. And so I think we'll know in a few years how to target TDCS and brain stimulation in general to some of the mechanistic factors specific to the disease as we move forward.
Yeah, it's interesting. I think in many applications, it's becoming clear that it's likely to become, it is, and it's increasingly likely to become more of a complementary kind of treatment and work in a personalized sense, as you're talking about, like to not replace, but to complement the medication side or the physical therapy side. Yeah.
That's exactly it. And it's so deployable so that somebody who's suffering now, it should be the first and not the last choice, right? It should be the first choice. And it can be provided to people waiting for an appointment. For instance, even if you have depression, you could do TDCS while you're waiting for your psychiatrist appointment. So it's so deployable in that way. Or have impairment, sudden impairment, and you're going to cognitive or PT or neurorehabilitation, you can have TDCS added right away to that to enhance the recovery. So I really do see that exactly in the future as alongside and enhancing other therapies as well. So it doesn't have to replace anything, but it definitely deserves a place along everything alongside the other treatments.
Yeah, I'm curious, do you think that there would be potential for treatment of like other more perhaps debilitating symptoms like the spasticity and perhaps more advanced disease?
So we think so. Dr. Pilloni can talk about spasticity some. Those are harder symptoms when it's motor control. And also there's some evidence with spinal cord lesions in particular, maybe a specific consideration for people living with MS.
Yeah. Yes, but at the very beginning, actually, TDCS was especially in MS, was like tested a lot for spasticity because they were like, I think like TMS for spasticity is a better choice than TDCS for how it's like because there are different mechanisms of action. While there is some study, for example, in MS and spasticity using TMS that are promising, while they were not really promising the use of TDCS for spasticity. By spasticity then comes with all the functional motor limitations. And then probably TDCS can help, but not really like treating spasticity per se, but more as an add-on intervention during rehabilitation with patients with spasticity.
Yeah. But in our progressive study, the hand dexterity trial, people had pretty severe disease, and that was the purpose of that. That was a special research program through the DoD to reach those people because they've been really overlooked and understudied, or even thought earlier in my career, it was thought that there was no recovery potential once you reached a certain stage. And I think that's absolutely disproven at this point. So I don't think anything's too severe to try to help. TDCS may have to be optimized, or we may need something stronger, as Giuseppina saying, but I definitely think that brain stimulation can be helpful all the way through to help improve things for people. So there's not like a early window that you should only use it in.
Yeah, no, that's great. Were there any kinds of common side effects or other sorts of drawbacks that you found from participants or in the clinical applications for these kinds of problems?
I'll refer to Dr. Pilloni, who did a very ambitious analysis of all the side effects that we completed across trials.
Yeah, I think so. We already said that TDCS is a feasible intervention to be deployed at home, but like sometimes when I like talk with other colleagues, they always wonder what is safe when you do this intervention in a home setting and you don't have direct control. And the answer is very simple, is yes, but there is some component you have to take account when like you do your study. Because, okay, first of all, you have to use medical grade TDCS device with all medical grade component. Unfortunately, the reality is that sometimes when no proper equipment is used, TDCS can cause burning lesion, but this not should be the case, because TDCS, when performed correctly with like sponge electrode, using saline solution in the right amount, you should not have any of these burning lesions that have been reported. It's more so, and in our review of all the side effects that happened in our previous trial, we found like that patient may report the same side effect of TDCS when TDCS has done like in a setting like a clinical lab. It's just like a skin sensation, like tingling, itching, and like warm sensation under the electrode. But this is mainly because it's a Joule effect that is a current passing through the skin, and this causes little bit of overeating, but like it's nothing that is not tolerable. And actually then we found the sham participant reported the same amount of side effect that active participant. So there is no really concern in terms of what they define side effect, but like right now, we are also not anymore reporting them as a side effect, because like it seems a normal consequence when you are applying like something, like you are applying a low intensity electricity. And also there is no concern when you do repeat the session for multiple like days.
Yeah, so that makes sense. I guess in a similar way that there could potentially be a placebo, then there's this concept of the nocebo, and
Right.
side effect whenever there's an idea about electricity being applied. But it is I really appreciate that commentary, because I think even before we started recording, we had a brief chat a little bit about the concern in terms of TDCS in general around, because it is very exciting in terms of the applicability and the broad nature of targeted disorders and symptoms, that opens the door perhaps for actors to produce units that are not medical grade. And it's important for people to understand that in order for this to be safe and effective, that it has to be done in a way that's based on rigorous studies and with equipment that is medical grade and has been properly engineered.
Right. And always in the context of clinical care. And I just think it's about safety, of course, but also for efficacy, because I just don't, we have people who, just for cost, unfortunately, and that kind of thing, do go out and find their own devices and just use them. But using without guidance and without partnership, it's hard to evaluate. It's hard to do routinely. And so I do think that this belongs in the context of clinical care, even in the home setting, either in a prescription service or in partnership. I just really do think that that's a really important part of the treatment to get something out of it.
Yeah, no, for sure. And that speaks to this real benefit and attractive nature of the accessibility, the scalability, the equitable nature of people, not necessarily, like you say, even when they're on a wait list to see a physician or the practitioner and to start some other kind of multimodal treatment, they can just start the TDCS at home already. So can you speak a bit more about what would be some next steps in terms of making it even more accessible to folks, especially those maybe in more rural settings that don't have access to the research level institutions?
Yeah, so our clinical service, we can reach anybody in the United States that has Wi-Fi connection, which is pretty remarkable now that everybody has one. So it's very accessible, but unfortunately, the clinical part is the cost is a rate limiting factor. And we need a company to get approval, and ideally it should be covered with insurance, right? So that people should not have to pay in our model for any of their care. It shouldn't be special that they have to pay for TDCS. And so that's got to move in some direction with FDA approved indication for use, which is unfortunately we're an outlier here in the United States, but most countries do have some approved use. And so anyway, that's really the biggest. I think once we have that, then we can move forward and a lot of other uses can join. Dosing optimization is critical, right? So we need to know how much is minimal for benefit, how much for plateau, how do you know, how do you maintain it, what's boosting, all of that kind of outer dosing especially is really important. I think there's a really exciting trend in the field, started with TMS called accelerated or TMS and TDCS, where you do multiple sessions a day. And we don't know whether reaching a goal, you need a marker or a goal, right? So they're using depression in these trials. So that, for instance, doing 10 space sessions versus accelerated and all in one day, can you reach the same goal quicker? Clinically in our service, I believe I've really seen, I think the brain can only change so fast at a certain rate. And so you can't really expect something like that although some people do achieve benefit. So how to use that kind of thing and all these innovative dosing things. Dosing. Well, and dosing is really the two things that I would like to see. Giuseppina, do you have?
No, I agree. I think I'm more toward dosing personalization. So really trying to understand. We go back to what we said before, really like find biomarkers, response, and then working on that about personalization of dosing for patient. Because we saw patient that we have seen patient that respond and patient that don't respond. And we always wondering why.
Yeah, predictors, right? Is there anything that we can do? So everything's about the markers in the end, but so obviously no treatment helps everybody. And so trials will be more powerful if we can select, and certainly treatment would be more powerful if we know before you did 20, 40 sessions, if we knew something early on that could predict it's worth it or not to do all of that. That's what's really needed.
Yeah, no, for sure. And I guess it leads to a lot of unanswered questions that require further study. So yeah, do you have other projects on the horizon that have been, what's the proper word, that have been inspired by the studies that you've already talked about?
Nearest term is the depression study in MS, so close to our heart. And this is a really pragmatic clinical trial that I think will move us very close to clinical use and give us that clinical guidance, and to be able to look at just what you brought up, the point about how symptom experience and even functional aspects of symptom burden will move with the treatment in general, and then depression symptoms too. So we're really excited, and that's a nationally recruiting trial. So we're very excited to start that. And then Dr. Pilloni, Giuseppina's work with the HRV as a biomarker, because that I think will be a powerful generic, really, which is what we want, indicator of benefit. And so that once we have something defined like that, and especially in a closed loop application, that's really going to be the floodgates to being able to design a lot of dosing optimization studies.
Yeah. And I think we should also mention that we recently complete the trying to use TDCS for reducing cannabis use in patients with MS. Yeah, Senator. It was a pilot study, it was smaller, but it was a very cool study where we do you want to talk more about that?
Again, clinically, there's a high rate, no pun intended, but there's a high rate of cannabis use among people living with MS. It almost has a health halo effect. And so people are surprised, and there's really no evidence-based use outside of spasticity for cannabis. And so a lot of it's used for symptoms that don't have real clear benefit. And there's more and more studies showing that when you come off of cannabis, for people who have heavy use, they actually improve in terms of cognition, at least in well-being and depression. So how do you come off of it? And so that was the question, it sounds great, but I'm in this use cycle at the least dependent. And so there's a lot of interest in the broad addiction field for use of neurostimulation and TDCS in particular. So again, partnering with people living with MS really as a model for the addiction framework across diseases, and then nothing for cannabis. So that was also a model for something for cannabis. We designed a 1-month intervention pairing TDCS with mindfulness meditation to support the distress that comes up when you withdraw use that drives that use cycle. And our pilot study was a success in terms of really proof of principle, is just saying that people had reduction in cannabis withdrawal symptoms and in overall use, as well as in symptom burden. And they improved in the SDMT, the cognitive measure in MS, as well at study. And so again, preliminary pilot study, but very exciting, both for people living with MS and also if we can generalize that to cannabis use, which is very badly needed, a tool for people who want to reduce their use, and then to test in other addiction models as well. So that's a real exciting, rapidly developing area too.
Amazing.
Yes, he's brought us across everywhere. Very interesting journey.
Definitely. Yeah. It really, that's incredible. What a really amazing, perhaps somewhat unexpected kind of finding in terms of the idea, and then taking just the experience, as you say, of what are patients with MS doing historically, and what kinds of challenges are they facing historically, and how might this technology help with these other things. I love it how all these thoughts are leading to new innovations and potentially new therapeutic options for people.
Yeah, for sure. And our wonderful collaborators. So it's really a wonderful community, I'm sure we brought us together for the podcast, but it's just people are so interested in designing and advancing this new therapeutic area to clinical use and to help people. So it's a really exciting time, I think, for that.
Yeah. Do either of you have any kind of closing thoughts around messaging that you would want to share with clinicians, patients, policymakers about your work and the promise of this technology?
For it should absolutely be indicated for use in the United States. That removing the cost barrier for people to have access now. There's no reason that TDCS, especially for the treatment of depression, shouldn't be available now as an option. Doesn't have to replace anything, but it should be an option because it's so effective and deployable.
It should be the first option. There is no side effect behind.
And there's so many special populations that can't or won't tolerate medications, and so again, there's so many people in pain, and just being able to have that as an option for people. The message for the science community is to keep going and to report dosing and think about all the dosing parameters and help us define dosing as a field and to be consistent so we can compare studies and to study more than 20 sessions to look at it in that way.
Yeah, it's really inspiring. Yeah, I know. I was initially made aware of your work at the Brain Stimulation Conference in February in Japan, and so I appreciated seeing the poster there and being introduced to your work there as well. But what you were just saying about the issue around it should be approved and then soon after hopefully covered by insurance companies, surely there are going to be increasing studies coming out that can show or support the cost benefit analysis in terms of the improvement in functioning.
Yeah, unfortunately, the reason that we're an outlier is the FDA rules on the basis of a marketing application. So a company has to come forward and say, we want to market it for this indication. So they're really approving marketing indications versus ruling whether it works or not. And so that's unique to the US market. And so the TDCS is very hard to, as a defensible technology for a single company. And so that is really hard for one company to put forward and defend, right, once they pass that bar. Is my understanding. I'm no expert in that field, but that's one of the unique features of the US marketplace. So we wish that it was a governing body that just said, oh, this is effective, therefore it should be available, which unfortunately is not the case where we are.
I suppose as the pressure mounts based on the growing evidence base, then it hopefully would become inevitable. But yeah, as much as we can do to advocate in these small ways is important.
Yeah, absolutely.
Yeah, for sure. Okay. Is there anything else that either of you wanted to talk about or that we haven't touched on yet that you think would be interesting?
No, I think we covered.
Perfect. Yeah, that's great. And I really appreciate both of your valuable time and spending that time here talking with us today. And for viewers and listeners, again, I'm going to put the relevant links in the show notes. I would really encourage you to check that out and just explore more about these researchers' work and the clinical programs that are available as well. And hopefully we can connect at a future conference maybe. And
we really appreciate the opportunity to share and discuss some of our work with you. So this is great. So thank you.
Fantastic. Okay. Thanks again. Have a great rest of the day.
Okay. You too. Bye-bye.
Okay. Thanks a lot. Bye-bye. That wraps up our conversation today with Dr. Charvet and Pilloni. A truly inspiring look at how remotely delivered neurostimulation is not only scientifically sound, but also practically feasible and clinically meaningful. Their research into RS-tDCS for people with multiple sclerosis reminds us of a broader truth. Accessibility and innovation can go hand in hand in neuroscience. If you're a clinician, a researcher, or somebody living with MS, I hope today's episode sparked new ideas about what's possible when we bring therapy into the home. Don't forget to subscribe to this podcast, share the show with someone that you think might be interested, and ask questions or leave comments or a review in the comment section below. For more resources, references, and links to the published studies that we discussed, and to Drs. Charvet and Pilloni's work and other research publications, please check out the links in the show notes. I really appreciate your time, your attention, and your interest, and I'll see you next time on the Neurostimulation Podcast.